Good afternoon. First of all, I'd like to thank organizers, especially Alexander and Ljubljana, for inviting me here in Belgrade, and it's a great pleasure to be here. Chronic rhinosinusitis is a disease with high prevalence of more than 10% in adult European and US population, and traditionally it's been divided to CRS with nasal polyps and CRS without nasal polyps. These are endoscopic pictures of nasal polyps in the middle nasal meatus and discharge coming from middle nasal meatus. And these are pictures of nasal polyps with edema and discharge in the middle nasal meatus. And on the lower right picture, we can see accessory ostia due to chronic rhinosinusitis without nasal polyps. It's never too much to stress that we don't need any X-ray to make diagnosis of chronic rhinosinusitis because we are looking for endoscopic signs. And when needed, we make imaging, CT or MRI scan. When the diagnosis of chronic rhinosinusitis is not clear enough, we have positive CRS symptoms, but don't find any endoscopic signs. In differential diagnosis, it could be recidivant acute rhinosinusitis, allergic rhinitis, or rhinogenic headache due to contact points, or atypical facial pain with trigeminal hypersensitivity, which can be local or central. And it can also be migraine. We make CT before any FAS operation and when we suspect complications, intraocular or intracerebral, or unilateral pathology. These are pictures of recidivant acute rhinosinusitis or allergic rhinitis. We can observe very hypertrophied mucosa of inferior turbinates. This is a picture of central compartment syndrome in allergic rhinitis, which was already mentioned this morning, with a lot of hypertrophied mucosa in the nose and with bullous middle conchas also. And these are pictures of rhinogenic headache with nasal spur on the right side and bullous middle turbinate on the left side. So CRS headache should be on at least 2 consecutive days. It should last more days, usually from 5 to 7. And it is usually localized over the involved sinus that can be on the forehead, behind the eyes or between the eyes, zygomatically, or even upon chewing dental pain. And it can be on the top of the head. Usually it's worse when the patient is leaning forward or walking the steps. This is a picture of chronic rhinosinusitis with nasal polyps. We can see very thickened mucosa in the sinuses and in the nose, in the middle nasal meatus. This is even worse picture of a patient. All the sinuses are filled up, and in the right picture we can see laterally in the frontal sinus mucocele formation. On the other hand, CRS without nasal polyps would have only sinuses filled up and just slight edema in the middle nasal meatus, or maybe discharge. Another example with thickened mucosa in the maxillary sinuses and ethmoids. These are signs of long-lasting inflammation in chronic rhinosinusitis with nasal polyps. We can see osteitic changes of bony walls of sinuses and fibrosis coming along with it. And what is it going on in pathology? In eosinophilic nasal polyps, we have pronounced eosinophilic inflammation. That means more than 10 eosinophils per high power field. These eosinophils are activated. They secrete toxic proteins. The degranulation is going on, and so we can observe Charcot-Leyden crystals in the eosinophilic mucin. We also can observe peripheral blood eosinophilia. And these eosinophils are linked to the type 2 inflammation, which is mediated by Th2 cells and innate lymphoid cells type 2, which secrete IL-5, IL-4, and IL-13. This is an example of eosinophilic nasal polyps. On the left side, the same patient after 6 months of symptoms, and on the right side, the same patient after first operation already, but the disease is getting worse. We can see this mucocil formation in the lateral part of frontal sinus. Again, the same patient. And here also we can observe a huge difference in the disease progress time. The non-eosinophilic nasal polyps have mixed Th1, Th2, and Th17 inflammation. And CRS without nasal polyps is endotypically more heterogeneous. Sometimes we find Th1 inflammation, and in less than half of patients, Th2 inflammation. The innate immune system in this chronic rhinosinusitis is exaggerated, is continuously activated by viral infections, and then it causes epithelial shedding and damage. The mucosal glands secrete too much mucus, which is too thick, and sometimes it could be also beneficial. For example, like in intestinal protozoal infection, the mucus could clear the protozoal out of the body, but not in the nose. It promotes type 2 inflammation. This innate immune system was given to us by evolution, but here it's not effective. So treatment of the CRS is still not good enough in some patients, especially in those patients that have severe persistent CRS symptoms and one after another recurrence after surgery. As we heard this morning, biologicals still don't justify their high cost and the risk factors they carry along. So we should search backwards in the inflammation cascade. That means gene-targeted therapy for the upstream targets like transcription factors. The transcription factors are molecules that promote just one line of Th cells, or the effector cells, or maybe T regulatory cells. And the new principle of therapy would be that the short particle of DNA would bind to the specific messenger RNA region. It would cause cleavage, and then we don't get any product. We don't get the transcription factor. In this example, GATA3, which is responsible for type 2 inflammation. So in asthma, it has been found that this way, with dianazyme, the type 2 inflammation has been attenuated. The transcription factors are intracellular, and they are specific for each lineage of Th cells. Here we can see the list of transcription factors that are interesting for us for chronic rhinosinusitis. Tbet factor is specific for Th1 inflammation. GATA3 is specific for Th2 inflammation. RORC for Th17, and FOXP3 for regulatory T cells. So this is our study design. 22 patients were included, 14 with nasal polyps and 8 without nasal polyps. They were diagnosed for the first time, not yet treated. They had positive CRS symptoms, positive endoscopic signs, and CT scans. We excluded aspirin-exacerbated respiratory disease patients and cystic fibrosis patients. We made biopsy, which was observed by pathology, and then the transcription factor gene expression levels were measured. That means their messenger RNA for these factors were measured by PCR method. In pathology, of course, nasal polyps were characterized by eosinophilia. 71% of patients with nasal polyps had eosinophilia more than 10 eosinophils per high power field, and that was the eosinophilic nasal polyps group. We also observed thickened basement membrane. That means remodeling and fibrosis going on in these eosinophilic nasal polyps, so that means more severe inflammation. And the non-eosinophilic nasal polyps were those with less than 10 eosinophils per high power field. We found upregulated Tbet. That means the transcription factor for Th1 cells and also for innate lymphoid cells type 1. This transcription factor depends on interferon gamma. It can activate or modulate, it means suppress, the type 1 inflammation. It is highly expressed not only Th1 cells, but also in CD8 plus cells. And this finding correlated with our recent findings from flow cytometric study that the CD8 cells were elevated in CRS without nasal polyps, and they were effector and highly cytotoxic. Sometimes the Th1 inflammation correlates with infection clearance and improved infection control. So yes, we confirmed in the CRS without nasal polyps the type 1 inflammation. The GATA3 transcription factor, which is responsible for type 2 inflammation, is expressed in Th2 cells and innate lymphoid cells type 2. And we found elevated GATA3 in eosinophilic nasal polyps. But in our recent study, in flow cytometry study, we found elevated also double negative cells, that means CD4 minus, CD8 minus cells, which also are able to secrete the same cytokines, IL-5, IL-4, and IL-13. So we are questioning ourselves now that maybe are the double negative cells also linked to GATA3 elevated in eosinophilic CRS. But surprisingly, GATA3 was elevated in CRS without nasal polyps. And we found data from the literature that CD8 cells can also secrete GATA3, and the CD8 cells were elevated in asthma with producing cytokines of type 2 inflammation. In our recent study, also activated effector CD8 cells were elevated in CRS without nasal polyps, maybe linked to GATA3 also. We found also elevated RORC, that is the Th17 transcription factor in chronic rhinosinusitis without nasal polyps. Th17 cells are not good in asthma, but in nose they are good. They promote normal immune response, homeostatic immune response to everyday infections, and we can find a lot of Th17 cells in healthy nasal mucosa. In our previous flow cytometric study, we also found the Th17 cells were linked to good disease control in nasal polyps. So we can conclude from this that maybe CRS without nasal polyps has better preserved normal mucosa and normal immune response. And the last transcription factor we analyzed was FOXP3 gene expression. That's a factor for T regulatory cells. The regulatory cells are sort of policemen in the nose, in the mucosa, because they suppress inflammation. And each regulatory cell is responsible for one type of effector cell. And in this way, it should co-express another transcription factor to be able to localize the effector cells. We didn't find any difference between nasal polyps and CRS without nasal polyps, but regarding the FOXP3 transcription factor and co-expression of another transcription factor, we have to be careful. If we block one transcription factor, we would block also the responsible regulatory cell. What's needed in the future? The transcription factor targeted therapy is promising, but needs further data, and the RNA sequences should be done to search for new targets, possible targets in the inflammation. And of course, DNazyme molecules shouldn't just block inflammatory Th cells, but they should spare the regulatory cells. Thank you very much for your attention. Let me conclude. This is a nice picture of my children spending summer. Thank you very much.
Do you have any question?
Thank you very much for the presentation. It's nice data. You didn't see that non-polyp that patients with polyps have low T regulatory cells expression. Although you look for the factors, but you didn't see it. No, because you know that the first papers was
some papers
hypothesizing that it is due to low regulation process.
Yeah.
The polyps. No.
Thank you for your question. Very interesting question. Yes, it was found a couple of times that the regulatory cells were deficient in nasal polyps, and this way they were not able to stop the inflammation. But afterwards, there were also studies that didn't find any difference. Neither did we. We didn't observe any difference in regulatory T cell presence.